Welcome to Dirtyberg, where training is continuous. I'm JT, and this is Chalk Talk. Today, we are going to discuss the first wave of the EKG, the P wave. The P wave is the electrical representation of atrial depolarization and is the first phase of the cardiac cycle. Mechanically, the atria is contracted. The reason for the contraction is to create pressure within the atrial chambers and force blood through the atrioventricular valves, the tricuspid valve, located between the right atrium and the right ventricle, and the mitral valve, also known as the bicuspid valve, located between the left atrium and the left ventricle. And the blood does not flow superiorly due to A, gravity, and B, due to the direction of contraction. The ventricles and atria contract in opposite direction to allow perfusion to take place. Otherwise, blood would not be going round and round, which is what we like to see. To think of this easily, notice the musculature of the heart. Muscle tissue, like we talked about in the last Chalk Talk, is made up of cells. The heart has two types of myocytes, or muscle cells. We have contractile cells and we have conducting cells. The difference is just what it sounds like. Contractile cells act like our skeletal muscle cells, where their job is to squeeze, which is contraction, and causes pressure to build up in the lumen of the chambers and propel blood forward. Just like if I had a water bottle filled up to the top with no cap. By the way, I mean a literal cap. Not as in, I'm telling the truth, like my 11-year-old says. Anyway, when my hand squeezes the exterior of the bottle, it's going to cause a pressure buildup inside and flow the water out of the top. No cap. Now, the conducting cells set up the speed and direction of contraction. These cells, which include the SA node, AV bundle, and Purkinje fibers, conduct the action potential across their tracks throughout the heart and cause the contractile cells to depolarize along the way and contract in a specific order, as we see here. Atrial contraction versus ventricular contraction paths. The direction when compared to where our leads are placed and what view we are looking at create our deflection on the EKG. The axis, or mean vector of travel, is going to be somewhere between 0 degrees and 75 degrees because of the path of these conducting cells. Because of that, we are going to get the best view of our P wave in lead 2. In lead 2, a healthy P wave is going to look monophasic, or in only one direction, and is going to have a smooth contour morphology. Compare that to AVR, where it's the opposite and traveling away from the view. Still should be smooth, however, it will be inverted. Now, although the conducting cells are fast, we still have depolarization starting in the right atrium. If we remember, the SA node is typically the conducting cell that starts this whole process, which means the first 1/3 of the P wave is right atrial activity, the last 1/3 is left atrial activity, and the middle 1/3 is the combination of the atria depolarizing. The machine is just not fast enough to be able to represent each atrium on its own. It combines together and forms one morphology, except in one case, V1. The reason V1 is biphasic is because of the unique vantage point it has on atrial activity. As we said, the first 1/3 is right atrial activity, and that heads towards V1, so we get an upward or positive deflection. And then as the conducting cells continue towards the left atrium, it is in a direction that is away from V1, so we clearly see the left atrial activity separate from the right in this one lead. Now, for today, I want to focus on only two P-wave abnormalities. We will touch on the others later on, so it's not too much to handle in one short lesson. The two we are going to talk about today are called P mitral and P pulmonale. These are both signs of atrial enlargement. A quick point I'd like to touch on is enlargement versus hypertrophy. Hypergrowth in an atrium is termed enlargement, while hypergrowth in a ventricle is termed hypertrophy. The actual medical definition of enlargement is an increase in chamber size, and the hypertrophy is an increase in chamber wall thickness. Often it is said that enlargement occurs because of volume overload, while hypertrophy is caused by pressure overload. But that's not always the case and should be treated as dogma. Also, the EKG is poor at identifying true enlargement versus hypertrophy. For that, other imaging needs to be conducted. But with all that being said, we are able to detect hypergrowth, whether it's enlargement, hypertrophy, or some combination. Now going back to the morphology of the P wave. Since the first 1/3 is the right atrium, with right atrial enlargement in lead 2, we will see a tall P wave, possibly with a notch towards where the left atrium is depolarizing, but that's not always the case. Because we have increase in tissue size of the right atrium, we have increased amplification of the wave itself just prior to the left atrium, which is normal here. The P wave in right atrial enlargement is usually tall, above the normal 2.5 millimeters in lead 2. Things are slightly different in left atrial enlargement. Since the left atrium depolarizes after the right, the overall time it takes for the P wave to finish depolarizing is abnormally long, more than 120 milliseconds. Often, because of the time it takes the enlarged left atrium to complete depolarization, and it being after the right atrium, it will usually allow us to visualize the separation of the two peaks of each atrium. P pulmonale, or the peaked T waves we saw earlier, are seen with right atrial enlargement. And P mitral, or the bifid waves, are seen with left atrial enlargement. The first way I remembered which was because the bifid morphology kind of looks like an M for mitral. P pulmonale is usually due to pulmonary hypertension, hence the name pulmonale, because of right-sided heart failure, or cor pulmonale. Increased pressure in the lungs arteries are either chronic or acute. The latter will typically be from a pulmonary embolism, but chronic is usually due to COPD or other lung tissue damage. So usually a patient with right atrial enlargement has COPD. P mitral is typically from mitral stenosis. The narrowing of the mitral valve orifice causes an increase of pressure in the left atrium and thus makes it work harder, just as the right atrium has to work harder against pulmonary hypertension. This is similar with the ventricles and their enlargement. Any cardiac muscle, just like skeletal muscle, will increase in volume if it has to contract under a greater load. Tension causes hypertrophy. Imagine you're doing a bicep curl. Your bicep muscles being your heart in this example, and a dumbbell being the added resistance, would be the narrowing areas the atria have to pump against. The muscle will adapt and growth will occur. Obviously, this is a problem in our heart because when the chamber lumen proportions change, it's a cascade effect, which is why left ventricular hypertrophy will eventually create right ventricular hypertrophy if left unmanaged. And since it has the potential to cascade, we can definitely see biatrial enlargement when both the right and left atrium enlarge. With that, we will see a combination of P mitral and P pulmonale. So, to recap, we talked about the difference between contractile cells and conducting cells, where the conducting cells create the order of contraction, and contractile cells being the ones that, together, cause the muscle to squeeze or contract. That the normal P-wave morphology, size and duration, are smooth and round, less than 2.5 millimeters in height in lead 2, and slower than 120 milliseconds. P mitral, typically caused from mitral stenosis, has bifid waves due to the prolongation of the left atrial depolarization because of that chamber's growth. And P pulmonale, typically from pulmonary hypertension, has a tall peak and a possible notch towards the end of the right chamber's depolarization due to its growth. Hopefully this helped you visualize atrial depolarization a little more. In next week's Chalk Talk, we'll be discussing the Q wave.
Don't forget to like and subscribe.